pregnancy patients, how you will need to recognize these patients and what will be the pathway and how to do a good shared care for these women who has diabetes complicating pregnancy. Then we will ask a physician to talk about how the medical management, the medicine part of it comes into play, giving multidisciplinary care to these women so that they have an optimal outcome. We also know that diabetes not only when it complicates, it complicates obstetrics part, but it also has an significant impact on the baby as well, or the neonate as well. So lastly, the neonatology management of a baby born to diabetic mother is going to be discussed. So that will be our agenda for the next couple of hours. While I talk to you about obstetrics part, if you have any questions that you need to ask or any clarifications that you need, you're quite welcome. I'll give time at the end to ask questions, as well as you can post questions using chat. You can use chat feature to post questions and clarify issues that you come across while we discuss the obstetrics part. So what I'm going to talk to you today is about, okay, what is gestational diabetes or diabetes complicating pregnancy, and a little bit about the definitions. Then we'll talk about why this topic is important, particularly important in Sri Lankan setting. And we'll see why this condition is actually a spectrum of disease conditions, where the glucose tolerance impairment or impaired glucose tolerance is manifested to varying degrees, and how that varying degrees actually, the severity or the spectrum of the disease, how it affects the mother, the management, and the baby. Then we will talk a little bit about how to manage a woman who is already diabetic and who wishes to become pregnant. Then we will come to discussing about recognizing impaired glucose tolerance in pregnancy or gestational diabetes, and what to do once you have recognized and once you have screened, recognized, and diagnosed gestational diabetes. Then we will talk a little bit about what's happening currently in this field and where we are probably headed in terms of managing this condition. So that's going to be our roadmap for the next 40 minutes or so. Now, WHO says that carbohydrate intolerance of any degree, which happens in pregnancy or which is first recognized during pregnancy, is considered gestational diabetes. Now, there's a diabetes that where there's prevalence. Okay. Now, there's also diabetes that is prevalent in younger generation, and with pregnancies happening later in the woman's reproductive years, there's a significant chance that women are actually diabetic to start with when they embark on the journey of pregnancy. And prevalence, when you see how much of diabetes complicates pregnancy, depends on where you are working, and especially if you are working in a place where place like Port 3, where lots of referrals are handled, then you see a huge amount of diabetic pregnancies. However, in referrals to all tertiary care in Sri Lanka, the trend has been to exponentially increase the mothers who get pregnant with diabetes over time. And what we know in terms of impaired glucose tolerance and its effects on pregnancy is that there's a continuity or continuous relationship between maternal blood glucose and the pregnancy complications. The higher the maternal blood glucose levels, the higher the average blood glucose levels, and the higher and longer that high blood glucose levels present in pregnancy, then the complications are more. So for a woman who has already got diabetes diagnosed, it is extremely important to manage that patient before she actually starts her pregnancy, because there are so many things that one can do to optimize the outcomes if you start before she becomes pregnant. So pre-pregnancy assessment or
recording in progress.
Preconception care is extremely important, and first trimester becomes important because in the first trimester, we know that most of the teratogenic effects of external factors apply to first trimester and the organogenesis time. Now, surprisingly, glucose in larger quantities is also teratogenic. So if you have higher blood glucose levels during organogenesis, there can be disrupted organogenesis and fetal malformations can occur. Pregnancy care is important for an outcome, for a successful outcome. And these women also need postpartum and contraception advice so that once you have a successful pregnancy, the lifestyle carries on and any future pregnancy is covered. We will talk a little bit about role of the primary care physician and how that person helps the obstetrics team in shared care. So if a patient is diabetic to and if you diagnose diabetes in a woman who is in the reproductive age group, and if she plans to become pregnant in the near future, what do we do so that she is optimized before she embarks on a journey of pregnancy? What we need to do here is to make sure that we achieve normoglycemia or as normal as possible throughout the day and throughout the time. So glycemic target achievements, ideally by getting HbA1c levels below 6 to normal, is ideal. However, to do this, generally, one might need to switch from large gamut of oral hypoglycemics available to some of the drugs that are pregnancy safe. And metformin, although we use it off license, which means it's not licensed to be used in pregnancy, is extensively used in pregnancy and is considered extremely safe and effective drug to be used in pregnancy. Generally, for every diabetic, including a diabetic who plans to become pregnant, the diabetic management should be multi-pronged, including diet, exercise, hypoglycemia awareness, and managing her body mass index. And it's likely that there might be additional medications that probably would impact on a pregnancy, like renal protection doses of ACE inhibitors, And if they are on statins, these drugs needs to be reviewed by her diabetic physician and the need assessed. If they're needed at the moment, pregnancy you might consider delaying the pregnancy with an effective contraception method, or on the other hand, if these drugs can be taken off safely, they can be taken off so that she has a planned pregnancy. The key with diabetic retinopathy is that as soon as you start, if you start very extensive control of blood glucose levels, existing diabetic retinopathy tends to worsen. And that is important because you need to get normoglycemia as much as possible. So we aggressively treat blood glucose levels in pregnancy. Therefore, it's important to check and exclude diabetic retinopathy with ophthalmology referral. And you need to have a dilated pupil and have extensive look, careful look and documentation of the retinal picture, and carry on with regular reviews for diabetic retinopathy. Diabetic nephropathy, on the other hand, has a significant impact on pregnancy. If the woman has diabetic nephropathy and her creatinine levels are high, placental disorders, including preeclampsia and growth restriction, is significantly increased as a complication. Therefore, this needs to be looked at before she becomes pregnant. So in preconception times, this needs to be checked for. Women who are diabetic will need a higher dose of folic acid to prevent neural tube and related disorders. So they should be started on a higher dose folic acid, generally 4 to 5 milligrams a day. And assessed for diabetic nephropathy, if the serum creatinine is high, she needs advice about contraception at the moment. Make sure that she's not going to get an unplanned pregnancy, and then refer up to make sure that diabetic nephropathy is sorted out or managed before she considered that pregnancy. If the woman has microalbuminuria, high serum creatinine levels, diabetic nephropathy, and pre-existing essential hypertension, these conditions are associated with a higher risk of preeclampsia and growth restriction, and they are at higher risk of iatrogenic preterm delivery. So that risk needs to be discussed with the mother. And especially if the woman is type 1 diabetic or has other autoimmune conditions, you might consider screening for thyroid disorders. And once you diagnose diabetes, one of the essential key features that you need to discuss with women in reproductive age group is to make sure that she understands that if she's going to be going to plan for a pregnancy, that needs to be pre-planned, optimized pregnancy. Therefore, optimal or a good, effective family planning methods needs to be discussed and agreed upon to make sure that she does not get pregnant. She does not end up with an unintended pregnancy, which can complicate so much. What is optimum glycemia? In terms of obstetrics point of view, we can when we discuss with the physician, when you have the physician input, it's more likely they will tell you that optimum glycemia is where you bring the HbA1c levels to normal or below 6. In terms of obstetrics point of view, we are more worried about glycemic, higher glucose levels having an impact on the baby, and especially so about the teratogenic effect of glucose. Now, teratogenic effect of glucose is well recognized. In fact, if your HbA1c levels are more than 10% at the organogenetic times, which means preconception and the first 12 weeks of pregnancy, chance of a congenital anomaly is 40%, 1 in 2. However, if you bring it down below 7, then the chance of congenital anomaly is for the background population. So you bring it down to the completely normal, or we bring down to the chance that the population chance, which is less than 3%, if you manage the glycemia well in preconception and during the first 12 weeks of pregnancy. So a preconception clinic visit at least 6 months or 4 to 6 months before a planned pregnancy is essential, as it can give huge benefits to the pregnancy that is going to be and success rates of that pregnancy. So make sure that the woman is on reliable contraception until she is ready, and ideally these women should be assessed preconception by a specialist obstetrician. And you should advise against pregnancy if the woman has advanced ischemic heart disease, advanced renal disease, and if the woman has proliferative retinopathy, pregnancy should be delayed until the treatment is carried out. So what does a primary care physician, or what does the community physician can do to optimize? You need to liaise with her diabetic physician or the endocrinologist. You need to liaise with the woman's obstetric team and make sure that the preconception and antenatal care is happening optimally. And whether there is pre-gestational diabetes or impaired glucose tolerance, glycemic control is extremely important, because as Sri Lankans, as South Asians, we are at a significantly higher risk of having diabetes, and coupled with the fact that most of us actually don't get the required exercises, and the fact that we lead hugely sedentary lives, seated down, which is really bad, working 8 to 10 hours a day seated, and then come home, sit down and in front of your TV, and carry a lot of additional excess weight. We are at a significantly higher risk as a nation to diabetes, as well as complications of diabetes, including pregnancy complications. So there is a national program of screening, and you need to make sure that you are aware about the screening. Because you will be working, most of you, once you complete, you'll be working independently, and you should be able to liaise and manage your patients in an optimal setting, including shared care of a pregnancy. So for a woman who has diabetes and planning to become pregnant, and their families should be offered information about how diabetes affects pregnancy and how pregnancy affects diabetes. And you should be careful when you impart knowledge and information, because when you impart valuable information, the patients do tend to hear what they really want to hear, and they might actually disregard what is most important. So making sure that you actually get the messages across is important. What sort of information that needs to be told? They need to understand how diabetes becomes a problem, and how diet, exercise, and ideal body weight can allow you to control your blood glucose levels and bring about optimal blood glucose control, and how that control actually helps you to prevent complications in the long-term renal, neurological, gastric, and ophthalmic complications, and in the short term, the pregnancy complications that you can manage by making sure that you are actually having optimal glycemia throughout the day. So one, you need to tell the patient that she needs to be assessed about her diabetic retinopathy and nephropathy before pregnancy. And whatever the medications that she's on, and folic acid needs to be discussed. And pregnancy is a time difficult to manage your glycemic control, especially in the first trimester of pregnancy. Pregnancy itself gives rise to multiple issues, and especially if they are excessively vomiting, they might not be able to take the appropriate food at the time they want, and it can adversely affect glycemic control in pregnancy. So what is the risk? Well, if you have a large for gestational age baby, there's significant chance that they might end up with birth trauma, and chance of preterm birth is increased. So is the chance that the pregnancy might end with a cesarean section. So maternal glycemic control is important, both during labor and birth, as well as making sure that the baby is breastfed early to make sure that the neonate doesn't get hypoglycemic and we avoid neonatal hypoglycemia. If the glycemic control is poor towards the latter half of the pregnancy, and if it is poor during labor and birth process, the neonate might end up with neonatal complications, and this will be dealt later today. There is transient morbidity to the neonate from including neonatal hypoglycemia, hypocalcemia, hypomagnesemia, etc., etc. Risk of respiratory distress syndrome is more, and these babies are more likely to end up with a special care baby unit or neonatal intensive care. There's also the risk that you might genetically, with environmental modifications of genetic message, that you might make your baby more prone, like the Barker hypothesis, where the intrauterine environment actually affects the baby's genetic modifications, and these babies might be at a later date at a higher risk of metabolic complications, including obesity, diabetes, and metabolic disorders in later life, and ischemic heart disease and related conditions. If the woman has thyroid disease, it is recommended, if the woman has type 1 diabetes, especially, they should be screened for other autoimmune conditions. So how should I screen? We were having a major list some time ago about screening these women. It is still true for women who at reproductive age group who present to you pre-conception. So if they have higher body mass index, if they have essential hypertension, women with polycystic ovarian syndrome, strong family history, women who are on steroids, and antipsychotics and antiepileptics, women who present with acanthosis and hirsutism and related conditions, needs to be screened for diabetes, especially so if they plan to become pregnant. But once, if they are pregnant already, then which patients do you need to screen? In that case, you need to screen everybody. So if you're going for preconception, you might go for a high-risk based screening. But in pregnancy, we do screen each and every pregnant woman for pre-existing impaired glucose tolerance and diabetes. And that is done at the booking visit. So how do we screen? Ideally, we can screen if the woman is less than 12 weeks, you can actually use fasting blood glucose, but the recommended screening methods include HbA1c levels, glucose challenge test, where 75 grams of glucose is used in a non-fasting state, or a full oral glucose tolerance test. So screen with either of these and make sure that each and every pregnancy is screened. Now, what happens in antenatal care for these women? These women need, because they are more prone to have later complications, and recommended timing of delivery is late term, which means you need to know the gestation very correctly. Gestation needs to be, you need to know the absolute correct gestation, because without knowing the correct gestation, any management about baby's growth or timing delivery is going to become impossible. So early pregnancy ultrasound for accurate dates is a must. If you look for neural tube defects and look for congenital heart disease, nuchal thickness related screening at 11 to 14 weeks is recommended. Because they are at a higher risk of fetal anomalies, a fetal anomaly scan is recommended, and especially for women who are diabetic, who were not well controlled and who are at a higher risk of placental disorders, including preeclampsia and intrauterine growth restriction, additional uterine artery Doppler screening and a 22 to 24 week fetal echo for looking for congenital heart problems is recommended. They need to be monitored for fetal growth using abdominal circumference at 24, 28, 32, and 36 weeks. Make sure that you liaise with the physicians and optimize the glycemia, diabetic educator nurses, the nutritionists, diet advisors, all are part of the team, making sure that women can gain optimized glycemia. And liaise with the primary care team, the medical officer of health. They can check, they have weekly clinics. So these women can just drop in to get their blood pressure and urine albumin checked once they are more than 20 weeks, if they are considered at high risk of preeclampsia. So diet advice needs to be given. Now, what about women who are normal? What about screening for gestational diabetes or pregnancy-related diabetes? So we do screen all women, each and every woman at booking. And what are we screening for? We are actually screening for pre-existing impaired glucose tolerance or diabetes, which was unrecognized because preconception care is not available to all our women with screening for diabetes. And a significant amount of our women in this country, especially the women who delay their pregnancies, who are obese and who do not get the exercise, recommended exercise, are at a higher risk of pre-existing diabetes, and that needs to be checked. And the earlier the gestation that you detect this, the better. And if they are normal, glycemic at booking, we all know pregnancy is a situation where placental hormones impart a significant anti insulin or insulin resistance. So placental, the hormone secreted by the placenta causes the woman to be insulin resistant. Therefore, they can become insulin resistance. That insulin resistance can manifest as gestational diabetes, and that screening is considered at 24 to 28 weeks rather than 28 to 30 weeks, which is a little bit too delayed. So we do it now at 24 to 28 weeks, and they are screened with a glucose tolerance test, 75-gram oral glucose tolerance test. What things to avoid? You need to avoid confusing information to the woman, and sometimes people still worry which woman that you need to screen. So if you remember that we need to screen each and every woman in Sri Lankan pregnancies for pre-existing diabetes and impaired glucose tolerance at booking. And then if they're normal, if they're recognized as diabetic, then you go for specialist care, multidisciplinary management of glycemia, the pregnancy, and the neonatal management. And if they're normal, they get a second screening for gestational diabetes at 24 to 28 weeks. And that screening test used should reflect the fact that later on you need to catch each and every woman, and needs to be sensitive and specific. So we do screen with oral glucose tolerance test, OGTT. So what is the cutoffs that we use for diagnosis? Well, there's a bit of a confusion about diagnosis cutoffs, but the cutoffs that we use are taken from Happo and the national guideline, and you should consider those cutoffs for our use. What are the obstetric complications of pre-existing or pre-gestational diabetes? The chance of fetal anomalies, chance of preeclampsia and growth restriction, and there's also the significant. There's also a chance that if this was uncorrected, there's intrauterine and intrapartum fetal loss, and medical complications including end organ damage and dysfunction. So optimizing glycemia is important. So we have discussed that. So how do we get optimum glycemia? We need to make sure that they achieve the glycemic targets achieved throughout the day and throughout the pregnancy. This will be discussed in greater detail when the physicians discuss with you how to get these glycemic targets. We check both pre-meal, which is considered the lower glycemic levels for the day, and post-meals, specifically 2 hours after the meal. Sri Lankan meals are, especially if you use low glycemic index foods, 2-hour post-meal glucose level is the one that we check, and that needs to be below 120. You need to advise about the diet. Metformin and insulin can be used, and women needs to ideally confirm that these things are happening. They need to take the blood glucose control onto their own hands, and they can do it with self-glucose monitoring with a glucometer at home, and that probably would be the best way to monitor. Diagnosis is of gestational diabetes at 24 to 28 weeks. Use 144 at 2 hours for glucose cutoffs. Although, if you go by the trial evidence, which came out with the Happo trial, preterm macrosomia seems to be was the end point in that trial, And that was significantly increased if the woman was having 153 or more in the oral glucose tolerance test at 2 hours. So again, screen all pregnant women, use 75-gram oral glucose tolerance test. And for women who are unable to fast, or if the fasting glucose or the full glucose tolerance test is not feasible, a 75-gram glucose challenge test in non-fasting state can be utilized. And that's allowed in the Sri Lankan national guideline. Do it at 24 to 28 weeks. And there's no longer two-stage testing where we screen for gestational diabetes. We do screen with glucose tolerance test at 24 to 28 weeks. We test each and every pregnancy that was considered normal and was not diabetic at the booking visit. So what sort of obstetric tertiary care we would advise? That needs to be in a multidisciplinary clinic. When you visit this Soisa hospital, you'll realize that we do have a diabetic endocrine clinic on Thursdays, and multiple inputs are put so that women get optimal glycemia and optimal control and have a successful pregnancy at the end of the day. So who are involved? You need to involve the medical officer of health and the woman's midwife to make sure that the follow-up can be arranged. You have the obstetrician, you have a physician who will help with complications as well as glycemic control. You will have diabetic educator nurses who will talk to them about their diet and show them how to monitor their blood glucose levels. You have a dietitian who will advise about the diets. And you also need some specialist referrals, including ophthalmology, nephrology, cardiology, etc. So there's this national guideline issued by the Family Health Bureau and Ministry of Health, so telling us that we need to screen all women. And screening in early pregnancy is basically for pre-existing glucose tolerance problems. And you can screen with glucose challenge test. If the initial screening was normal, you carry on with the pregnancy and screen at 26 to 28 weeks for diabetes, that is onset of gestational diabetes in pregnancy. And these women needs to be managed at a specialist-led clinic and needs to manage with glycemic targets and needs to be with a multidisciplinary team. So how do we go forward? If we can identify all the preconception, all women with preconception, then that would probably be the ideal. Because then we could manage that pre-existing diabetes better. Okay, so I'll stop it there and allow you to ask questions because we have 5 minutes more, about 5 minutes. So any questions or clarifications that you have on this topic, this is the time to ask.
Sir, may I ask questions?
Sure, go ahead.
Sir, can you please clarify again the difference between OGTT and GCT?
Okay. The OGTT is the diagnostic test and that diagnoses the condition. However, if you want to do a OGTT, the woman needs to be fasting. She needs to ingest glucose, 75 grams of glucose in a fasting state. And for some women, coming to the clinic fasting as well as ingesting 75 grams of glucose on a fasting stomach is difficult. So OGTT, although it's the ideal test in terms of diagnostic capability is a little bit of a difficult test to administer and difficult test to undergo for the woman concerned. So especially these data came from India, where this was for some women, they travel hundreds of miles to the clinic, so they can't really come in the fasting state to the clinic. So what they did was they looked at giving a glucose, 75 grams of glucose on a non-fasting state and making only one glucose measurement at 2 hours. And they realized that they can do fairly equally well to glucose tolerance test. So glucose challenge test done with 75 grams of glucose in a non-fasting state can be utilized instead of the glucose tolerance test, OGTT, if the woman has problems of fasting or if the woman has trouble taking glucose in an empty stomach. So that's the two tests that we use, and that's when we use them.
Thank you, sir.
Okay. Any other questions? Okay, so then I'll make time for the physicians to discuss about how this optimal glycemia. It's easy to say, look, you need to have optimal glycemia throughout the day and throughout the pregnancy until the 40 weeks are over. It's completely different matter getting it through to the patient and getting it. So let's hear how do we manage these patients and their diabetic complications, the medical complications of pregnancy.
Okay, good afternoon. This is Dr. Sachit, so I'll take over from there. Let me share my screen. Right, I hope you all can see my screen and hear me. Can one of you confirm whether you can see the screen?
Yes, sir.
Right. Right. So the objectives I'm going to cover in this part would be just to go through some different types of diabetes present in pregnancy, the diagnostic criteria, specifically what we use in diagnosing gestational diabetes. Some of this may overlap with the previous presentation, so I'll rush through those criteria. And then understanding the treatment goals and glycemic targets used in the management of diabetes in pregnancy. Then discuss about different options we have, the non-pharmacological as well as pharmacological management options to achieve these targets. Right, so when you say diabetes in pregnancy, that covers two areas. One thing is this gestational diabetes, and the other one is the pre-gestational diabetes, or we call it overt diabetes, which has been present even before the pregnancy. So that can be type 2 diabetes, or that could be pre-existing type 1 diabetes. So whenever you get a patient with diabetes in pregnancy, it is important to understand which sort of diabetes they have, because our management approach would be different. So what is gestational diabetes? So earlier it was thought that GDM was defined as any degree of glucose intolerance first recognized during pregnancy. So when you say that did not encounter the women with undiagnosed diabetes. So the new classification is that diabetes diagnosed in the second or third trimesters of pregnancy that is not been previously diagnosed as type 1 or type 2 diabetes. So that is gestational diabetes. So if you get diabetes earlier in the pregnancy, that will belong to either type 1 or type 2 diabetes. So, so this classification or this identification is important because our management of these patients and the complications, what we expect in these patients, are different. So as you know, there are a lot of changes in glucose metabolism in pregnancy. So early pregnancy, the estrogens, progesterones, they can stimulate the beta cells, so the insulin sensitivity and peripheral glucose utilization. So that can stimulate, and there could be fall in blood glucose level. So even with type 1 diabetes, sometimes, with the pre-existing diabetes, sometimes the blood sugars might go down a little bit in early part of the pregnancy. And you also know that the vomiting and nausea, those are common, so that affect their food intake patterns. So even in a normal diabetic patients, their glucose levels might go down a little bit in the first part of the pregnancy. But in the later part, you know that the fetal-placental unit, they extract these glucose amino acids, and they produce the other hormones, placental hormones, especially the human placental lactogen, the placental growth hormone, cortisol, the other hormones which have anti-insulin effect. So therefore, in the latter part of the pregnancy, usually the blood glucose levels will rise. So even in normal diabetic patients, it will become difficult, or the control may get varied in the latter part of the pregnancy. So you have to adjust your medications according to their blood glucose levels. And this is the reason why you get gestational diabetes in this time period of the pregnancy, because of these hormonal changes. And then when the mother has hyperglycemia, the blood glucose, increased blood glucose levels will travel to the baby, and the fetal pancreas will then make more insulin. And when there is insulin, you know that it's anabolic hormone, and there will be macrosomia, or large for gestational age babies. That is because of fetal hyperinsulinemia. And the other thing is, now if this continues up to the time of labor, just after the delivery, the mother's glucose coming from mother's side will not be there, but the fetal pancreas is producing too much of insulin, and most of them will go into hypoglycemia just after the delivery. So that's why it is very important that you need to control your blood sugar throughout the pregnancy. And it's very important that when they go for the labor as well, they should have very good glycemic control. Now, some of these complications have already been mentioned, so I'm not going to go into detail. So if you look at type pre-existing diabetes, you know the normal complications of diabetes. You have done the endocrine and metabolism modules, so those are common. They get the microvascular and macrovascular problems, so those need to be screened for any patient who are suspect to have pre-existing diabetes, and they are at a higher risk of congenital abnormalities because of the glucotoxicity as well. But when you consider gestational diabetes, they because it's a short period, and the important first trimester is past now, and therefore they will not get congenital abnormalities, or they will not get these vascular problems, vasculopathies associated with diabetes. But there are many other problems associated with gestational diabetes. So some of them are listed: the macrosomia, preeclampsia, polyhydramnios, stillbirth. And then there can be a lot of neonatal problems, which you are going to hear in the next lecture. And then there's also mentioned that long-term, there's a high risk that mothers who get gestational diabetes, there's a very high risk that they will go on to develop type 2 diabetes later. So these women who develop gestational diabetes have to be on regular screening, at least once a year or once in 2 years, for development of type 2 diabetes. And then infants also, infants of mothers who had gestational diabetes. If they are large for their gestational age, they could later develop obesity, impaired glucose tolerance, and diabetes. So therefore, it is very important to manage the diabetes in pregnancy, both pre-existing as well as gestational diabetes, in the proper way. Now, I'll tell you a bit about this Happo study, which was the hypoglycemia and adverse pregnancy outcome study, where it was a large study involving more than 23,000 pregnant women. They did this 75 gram OGTT at 24 to 32 weeks of gestation. And unless the blood sugars were very high, they just managed managing the trial protocol without intervening. And then they look at the primary outcomes of birth weight, increased birth weight, rates of cesarean sections, neonatal hypoglycemia, and the cord blood C-peptide levels. That is an indirect indicator of insulin secretion of the fetus. So what they found was that now you can see it's a continuously increasing pattern in all these things, all these parameters, birth weight as well as rate of cesarean sections. But the interesting thing they found was that this rise started even with the glucose level, which we previously considered as normal. So the usual fasting blood sugar around more than 100, the levels are very high. So the main message this gave us was these complications, there is a continuous rise. So we have to find a situation where it would be both cost effective to diagnose and treat, as well as to reduce the complication rate. And all the other complications like the neonatal hypoglycemia, they are gradually increase as the blood glucose level increases, and the neonatal the cord blood C-peptide levels also continuously increase. So the final conclusions was that maternal hypoglycemia are less severe than used to define as the normal or diabetes, still cause clinically important perinatal problems. And for most complications in this trial, there was no threshold of increased risk. It's like from the very early stage of glucose elevation, they start to rise. And the risk of adverse outcomes continuously increase beyond the period of 24 to 28 weeks, which the time they included them in the study. And as glucose rises from the normal level, they start increasing. And higher the glucose, higher the complications they detected. So I think this was discussed, whom should be screened here. Although there are lists now, high-risk ethnicities, all of them should be screened. So we belong to that high-risk ethnicity. So all pregnant women coming in their first trimester should have screening for diabetes at their booking visit. Gestational diabetes, again, I think this is mentioned. All pregnant women should undergo screening for gestational diabetes in the period between around 28 weeks of gestation. Now, this method, although some places it is being used in some MOH clinics and all we have seen, but this is not a good method. Glucosuria will be there even in normal pregnancies. So this is not a diagnostic method. You need to screen with blood glucose test. To diagnose gestational diabetes mellitus, you need to use the OGTT to diagnose the pre-existing diabetes in the first booking visit. It is like the other non-pregnant adults. You can use the fasting blood glucose, HbA1c, and you can also use OGTT, especially if there are the fasting blood sugar or the postprandial levels are elevated. You can double check with the OGTT, or else you can do the HbA1c. If they are in the diabetic range, you can diagnose type 2 diabetes or type 1 diabetes, depending on the clinical situation in these patients. If there are no risk factors, or if the first booking visit ones are normal, then you can do the gestational diabetes mellitus screening at around 24 to 28 weeks, roughly around 28 weeks. And then the test we do is the oral glucose tolerance test. The glucose challenge test was also mentioned, and there you can do without fasting and see the 2-hour value. But generally, the more recommended test is fasting 75 grams OGTT, because when the comparison studies have shown that when you do just glucose challenge test with just one reading of 2-hour value, there is a chance of missing certain percentage, close about 20% of patients. So this will only be good if the patient cannot come fasting, or if the patient coming in a faraway place, then that may be a good solution. But in other patients, when you're doing it in the proper way, it should be 75 grams OGTT, a fasting level. So the first trimester diagnosis is quite similar. The cutoff values are quite similar to non-pregnant diabetic women, what we use. So it's fasting blood sugar above 126, postprandial more than 200, or OGTT again, 2-hour value about 200, or HbA1c above 6.5. So if the fasting blood sugar is between 100 to 125, or postprandial between 140 to 199, you can do the OGTT, 75 gram OGTT in these patients for the confirmation. If it is if you do it in the first trimester and diagnose pre-existing diabetes, then you need to screen for other vascular complications. The retinopathy, you need to screen their eyes. For the nephropathy, you need to do serum creatinines, urine albumin levels, those things. Screening for the neuropathy and foot problems are also important if the patient had diabetes for a longer period of time. And if they complain of any cardiac symptoms or sign like excessive shortness of breath, or chest pains or anything like that, they should undergo cardiac evaluation, and all patients should be auscultated to detect any valvular defects as well. So diagnosis of gestational diabetes. So you do the screening with OGTT around 24 to 28 weeks of gestation. So the more widely accepted criteria with the ADA, as well as recently WHO accepted criteria based on this Happo study, your fasting blood sugar should be if it is more than 92, 1-hour glucose level more than 180, or 2-hour glucose level more than 153. So this is these cutoffs were derived looking at the cost benefit of identifying the complication or minimizing the complication, as well as the benefit of treatment based on the cost. But in our guidelines, Sri Lankan guidelines, we have, as well as in the NICE guidelines in UK, so these are the proposed cutoffs. So the fasting blood sugar above 100, 1-hour glucose above 180, and 2-hour glucose above 140. So if any of them are positive, then we consider these patients are having gestational diabetes. So I mentioned about glucose challenge test. That is suitable only in few patients. When you do the non-fasting, if it's more than 140, you can diagnose gestational diabetes. This HbA1c is not recommended for diagnosis of gestational diabetes. That is only used to diagnose pre-existing diabetes in the first trimester. Right, so coming to the management of gestational diabetes, ideally, if possible, they should do self-monitoring of blood glucose as well, because it's very difficult to have overall good control just by monitoring once a month of blood glucose without knowing what happens in between period. So it's very important, whenever possible, whenever they can afford, they need to get a glucometer and check blood glucose level at home as well. So ideal thing would be at least 3 or 4 days, they check blood glucose the early morning, like the fasting blood sugar, as well as post-meal once in minimum. And they also can look at pre-meal once in a while to make sure that all are within the range. So these are the targets we would like to achieve. Fasting blood glucose or pre-meal glucose between 80 to 95 milligrams per deciliter. If you do 1 hour, it is less than 140 milligrams per deciliter, and 2 hours, it is 2 hours postprandial, it is less than 120 milligrams per deciliter. The purpose of doing home glucose monitoring is to make sure that these values are keeping within the range for the most period of time, because otherwise, if you just do once a month blood glucose levels at these times, if the patient has a better kind of diet on that particular day, you feel that you might see that glucose are under control, but then other days it may not be. So we sometimes use the HbA1c test as well to get an overall idea of their overall control, because if they are keeping these targets, they should generally achieve somewhere close to 6 to 6.5. The 6 would be the ideal target. Below 6 would be the ideal target. We'll try to achieve by trying to get these glycemic cutoff levels. We only cannot go by HbA1c alone as well, because you know HbA1c gives the average glucose value. Sometimes some patients may have very low blood glucose around fasting time and high glucose after meals. Then again, the HbA1c would be giving average value of reasonable control, but you know postprandials will be high. In that situation, whenever the postprandials are high, that is the main determinant of fetal macrosomia. All the times when the blood sugar levels are high, the baby will get higher glucose that will lead into macrosomia. So our aim is to, while keeping these glycemic targets when they check at home, try to achieve overall control with a good HbA1c level to show that their overall control is also good. One thing you need to remember is you cannot go by HbA1c alone, because some of these physiological changes, specifically patients can get anemia during pregnancy, so that can affect the HbA1c levels, and there is high red blood cell turnover. So when you do HbA1c, usually we do once in 3 months, but we need to do in pregnancy, we might need to do it more frequently. So ideally, we would like to have HbA1c below 6 in second and third trimesters, but some patients it's very difficult to achieve these levels. So at least 6.5, we need to keep that target. Because what studies have shown is that if you keep these targets, they are at a lower risk of having large for gestational age infants, preterm delivery, and less risk of preeclampsia. So that's why we need to try to achieve these targets. So most patients, about 70 to 85% of women can control gestational diabetes with lifestyle modification alone. So there should be the medical nutrition therapy. If there's a dietitian, they should meet them. Otherwise, it should be the standard diet we recommend for diabetes with less carbohydrates and more vegetables and other protein items. Depending on the patient's weight, might have to adjust this plan, and individualized therapy would be the best thing. They need to maintain adequate calorie intake as well. So general recommendation is to have around 175 grams of carbohydrates per day. And these carbohydrates should be with low glycemic index. And the glycemic load is important. That is the amount of carbohydrates they intake that they have to divide between the meals. So general recommendation is 3 main meals with at least 2 or 3 snacks in between. So one meal should have around 45 grams or 50 grams of carbohydrates. And then physical activity is also important. That has also shown to reduce blood glucose levels. So, and also improves insulin sensitivity. So that should also be encouraged unless there is a contraindication for pregnancy-related contraindication to do any physical activity. So when to initiate pharmacological therapy in gestational diabetes? When the target glucose levels, which I told you earlier, cannot be achieved with medical nutrition therapy alone, with the lifestyle changes as well, then you need to consider initiating pharmacological therapy. If you find that even gestational diabetic patient, if you find that the blood glucose levels are very high, like fasting blood sugars like 140, 150, those patients are highly unlikely to achieve normal glycemic levels required in pregnancy just with the lifestyle modification. So those patients, even at the beginning, would need to go on pharmacological therapy along with the lifestyle modification. But most of the others can start with the lifestyle therapy and then see how they respond. And sometimes some patients, although they are on lifestyle therapy or they're not diabetes, they might get high glucose levels if they were given these antenatal corticosteroids for the fetal lung maturation. You can watch up to about postprandials around 140. Above that, you might need to consider starting pharmacological therapy, at least temporary. So there is no hard and fast rule how when you would start, how would you call failure of the medical nutrition therapy. But if more than 20% of the time their blood glucose levels are out of those ranges, above 120 for 2 hours, fasting above 95 or 100, you need to think whether they will need pharmacological therapy if they have been compliant with the lifestyle modifications. So more than 20% of the time of their blood glucose are above that range, you might think of starting pharmacological therapy. So this graph shows the summary of what I have told you so far. So most patients, unless they have high glucose levels, can start with non-pharmacological therapy. So if the fasting blood sugars are high, like above 126, probably you might need to think of pharmacological therapy as well from the beginning. And then if the control is not achieved after lifestyle modification, then you can consider pharmacological therapy. So what is the preferred therapy? Insulin is the preferred therapy. It is the first line agent recommended for treatment of gestational diabetes. The oral options, so metformin is alternative. in selected patients, but metformin do cross to the placenta, and the baby will also get a small dose, but studies so far have not shown any complications with metformin. There have been studies following up these children who had metformin, but they have not come across with major problems, although there have been certain fat distribution changes in these neonates have been identified, but so far there are no other major problems seen. So it could be used as an alternative to insulin when there are problems in administering insulin. Other than metformin, all the other oral antidiabetic medicines are not recommended in pregnancy. Sulfonylureas, out of sulfonylureas, most of them will cross the placenta. There was a little bit of interest about this glibenclamide because it minimally crossed the placenta, and there were some cases where it has been successfully used in pregnant patients without any problems. But recent data have now shown that glibenclamide, even glibenclamide, it shows it is associated with higher rates of neonatal hypoglycemia and macrosomia than in patients who have been used insulin or metformin. So therefore, even glibenclamide is not recommended in pregnancy now. So only oral agent you are using is metformin, but insulin is preferred. So metformin has some advantages over glibenclamide. That's why it still is out there, being oral agent. It has lower mean birth weight, lower risk of macrosomia, and less maternal weight gain as well. If you compare with insulin, there's slight advantage that there's a lower risk of neonatal hypoglycemia and less maternal weight gain as well. You know, with insulin, you gain weight, but with metformin, you don't. It's a weight neutral drug, so you don't gain weight. So it may be a more suitable option in some obese diabetic patients. But there are few concerns that it may slightly increase the risk of prematurity of the baby. And we don't know the long-term metabolic influence on the offspring, although short-term studies are reassuring at the moment. So insulin, the main advantage is that it does not cross the placenta. And we can do frequent titrations of insulin. As the insulin resistance increases, we can titrate the dose and achieve the glycemic control. To get the optimum glycemic control, the self-monitoring is a very useful method to do. So which insulin? Almost all insulins are safe, but some insulins have not been well tested in pregnancy. For example, insulin glucine, insulin degludec, and insulin glargine, and the human insulin, inhaled insulins. We don't have much data, although small studies say they are still safe in pregnancy. So therefore, apart from that, all the other insulins are pregnancy category B from FDA, which is safe to use in pregnancy. And if there is predominantly patients having fasting hyperglycemia, you need to use a long-acting agents or intermediate-acting agents. So it either NPH insulin or insulin detamine can be used at bedtime. So I told you that metformin is also an option in certain patients where insulin initiation is difficult. For postprandial hyperglycemia, you need to have insulins which will cover the prandial rise. So those are the regular insulins, soluble insulins, or rapid-acting insulin analogs. Premix insulin can also be used or considered, but premix, you know that we inject twice a day, but most of the time you cannot achieve these ideal targets just with 2 injections during the pregnancy. So very, very rarely we use that, especially if patients find it very difficult to inject more frequent injections. Otherwise, you need to inject 3 prandial injections for 3 meals, as well as the long-acting insulins or intermediate-acting insulin at bedtime to control the fasting. Very few patients you might be able to get away with premixed insulin with adequate control. So this is to show that depending on the gestational weeks, how much of insulin that is needed. As you can see, the insulin requirement increases as the pregnancy progresses because of the insulin resistance. So accordingly, you have to adjust your insulin doses. And then I told you that the glycemic control during labor is very important as well, because if not, the babies can get neonatal hypoglycemia soon after birth. So patients who have been managed with medical nutritional therapy with good glycemic control can go into labor without any other interventions. So you need to monitor blood sugar every 4 to 6 hours during labor. And those who are on insulin, probably if the labor is prolonged, might need to change to intravenous insulin with dextrose, aiming to keep the capillary blood glucose levels between 72 to 126. So during labor, you need to have very tight control to prevent other complications that can occur in the baby after birth. So immediate postpartum period, most of the treatment, insulins or oral medications started for gestational diabetes mellitus can be discontinued after delivery because the insulin resistance will change after the delivery. But this is not relevant for a pre-existing diabetes. You have to continue their medications. Till then, you may be able to reduce the doses of the medicines. And then you need to monitor after discontinuation of the medicine, you need to monitor their blood glucose to identify few patients who may have ongoing hypoglycemia, so that we might need to restart medicines. So postpartum period, they should ideally undergo, once they come out of medicines, they should ideally undergo 75 gram OGTT around 4 to 12 weeks of delivery. The HbA1c is not very accurate because it reflects the past control more than the current control. So it should ideally be a 75 gram OGTT, where then you can see whether they have completely resolved of this gestational diabetes. And even if that is normal, they need to have continued lifelong screening for diabetes and pre-diabetes at least annually. And if a woman has gestational diabetes, is associated with increased lifetime maternal risk of diabetes mellitus for about 50 to 70% after 15 and 25 years of initial event. So most who get gestational diabetes can go into type 2 diabetes when they are followed up long term, but it could occur very soon if they are not careful with their diet or if they don't do other lifestyle changes. If they have pre-existing diabetes or pre-diabetes after, when you do the OGTT, you detect most of them will be in the pre-diabetic range, if at all, then they should need more intensive lifestyle interventions. Okay, so those are the important facts I think I need to highlight. And the summary is that screening of pre-existing and undiagnosed diabetes is important in the first prenatal visit. Gestational diabetes is diagnosed by doing the screening test at 24 to 28 weeks. We generally prefer fasting OGTT, 75 gram OGTT, and the monitoring of blood sugar is very important during pregnancy rather than just doing infrequent tests for monitoring. So self-monitoring, if possible, would always be encouraged. If you treat gestational diabetes mellitus properly, that reduces maternal and fetal complications. So majority of women can control gestational diabetes with lifestyle changes only. And when the pharmacological treatment is needed, it is insulin as the first line therapy. And all those patients with gestational diabetes should undergo a 75 gram OGTT 4 to 12 weeks after the postpartum period. And all these women should continue to have lifelong screening to detect the high risk of type 2 diabetes developing later in life. Okay, I think that is it. If you have any questions, I'm happy to answer now. So someone has asked what kind of physical activities. I mean, generally, any kind of physical activity is good as long as it will not cause any problem to the pregnancy, like high impact sports and all, which might not be ideal in pregnancy situation. Other than that, any kind of other physical activities would be okay for these patients. Yeah, do you all have any other questions? You can also put it in the chat if you want, or you can directly ask me. Right, so if there are no questions, then I think I can stop my part and can continue with the rest of the activity. Thank you.
Thank you, sir. Hi, can you see my screen?
Yes, madam.
Okay. So I have to talk to you about, I think you have heard about the obstetric part when you were listening to the pharmacological part. So now we are going to talk about the baby. Okay. So baby of diabetic mothers, are they at higher risk than other babies? Tarindu, what do you think? Do you think these babies are at higher risk than other babies? I'm sure you have heard stuff from the previous two speakers as well.
Yes, madam, that higher risk.
Why?
Because higher glucose amounts which will be transferred from the mother to the baby can result in higher growth of the baby, and that can lead to complications in the delivery.
Okay, good, all right. So in previous days, when both obstetric care and neonatal care was not advanced as today, the mortality was very high. So it was 65% of the babies used to die. But with better obstetric as well as neonatal care, there was a 34 decrease. And with, so improvement, there can be more improvement even than today. And with optimal care, mortality can be brought down even as much as making it similar to a normal pregnancy without diabetes, right? So the risk of congenital abnormalities is high. It's around 6 to 9% versus 2% of the normal population. As in, if there is a person with diabetes, the risk is 6 to 9%. Whereas a person without diabetes, the risk is 2%. Right. So can one of you tell me, Brahman, can you tell me what you are seeing here? What is this congenital abnormality?
Spina bifida.
Very good. Or you can also call it meningomyelocele, right? Good. So central nervous system abnormalities can occur with poor control of diabetes. Good. Let's look at the next one. Jordan, you're next. This may be a little hard, but do you think you know what this is? You can just guess. You don't need to know. Yeah?
Umbilical hernia.
Sorry?
Hernia.
More than the umbilicus, what about the legs? Can you see the legs are not the way you usually see them? Yes, so this is a baby with what is called caudal regression syndrome, right? So the pelvic area, those area has not developed well. True enough, the umbilical hernia is also there, but the main thing is it's caudal regression syndrome, which is seen in babies born to mothers with diabetes. Okay. Let's look at this. Janitor, what can you see in this X-ray? This is a characteristic X-ray of a GIT abnormality. Janitor?
Diaphragmatic hernia.
Oh,
Diaphragmatic hernia.
not diaphragmatic hernia. What can you see? There are two fluid levels. Anyone else would like to attempt? Quickly though.
Duodenal atresia.
Very good. So this is what is called the
Bubble.
bubble appearance. You can see two fluid levels. Well done. Okay. Right. So let's look at another picture. So this is basically the perineal area in a baby. The legs, baby is being held up with the legs. You are seeing the backside. What can you see here? This is a picture of an imperforate anus, right? So what I'm trying to show you is the babies born to diabetic mothers are at higher risk of congenital abnormalities, especially if hypoglycemia was there in the first trimester, where organogenesis occurs. So can Fazina, this is again an X-ray. What is this X-ray called and in what condition is this done? Fazina, it's not clear. Can you put it on the chat? You're not sure. Okay, Ramit. What about you? It's okay if you don't know. Is there anybody who has seen a similar X-ray? So this X-ray is done in babies with imperforate anus, right? So you leave a marker at where the anal open should be, and you try to see whether this is a high imperforate anus or a low imperforate anus. And it is done after 24 hours because you have to have air inside the intestines to do this, right? So this is a posterolateral shoot through X-ray. Specific X-ray done for imperforate anus. Okay, what about this? Does anyone know what this is? This is a Meconium Alias. So another abnormality seen in babies born to diabetic mothers. Ramit, what about this? This is again a central nervous system abnormality. What is this? Gaki, Iham, yeah, okay, go ahead. Gaki, Hamo, what is this? What is the abnormality shown? I'm sure some of you know. Yes?
Anencephaly, ma'am.
Very good. It's anencephaly, right? So part of the skull hasn't grown and the brain is exposed. Well done. So then there are lots of cardiovascular defects this can occur. which can occur, right? So here you can see hypoplastic aorta, hypoplastic left ventricle. So various things are there which can occur. Small aorta, blocked aortic valve, atrial septal defect. So many things can go wrong. So you can see the baby can be affected in a very big way if the mom's diabetes is not controlled well. Okay, Tejana, what is the abnormality shown in this picture? This you have done in the cardiovascular module. It's a revision.
ASD.
Very good. It's an
ASD.
ASD. Very good. It's a left to right shunt. It's an ASD. So again, this type of diseases are also common in moms who have diabetes. What about this, Tusal? Tusal, there's a defect here. What is this defect called? Pulasti?
A VSD, madam?
That's right, or a ventricular septal defect, right? Good. So again, what's happened here? Rasari? What is shown in this picture, Rasari?
Tetralogy of fellow.
Is it tetralogy of fellow? Look carefully. See, the aorta is connected to the right side and the pulmonary artery is connected to the left ventricle. Things have got switched, isn't it? What do you call that? Anyone else?
Transposition of great vessels.
That's right, transposition of great vessels. So you can see the whole gamut of congenital heart disease become more commoner if mommy is having diabetes. So it's so important to control it. Okay, Kirutikan, what is this abnormality shown in the kidney?
Cystic kidney disease.
Very good. Polycystic kidney disease. Yes. Kodipili. This is IVU. You can see something in the where the arrows are if you concentrate. Kodipili. Laksujan. Laksujan. No? Okay. Does anybody else want to attempt? So this is duplex ureters, right? There are two pelvises, two ureters. You can see it on top. Can you see there are two pelvises here? So these are duplex kidneys, two ureters coming and opening to the bladder. So again, another genitourinary abnormality. So we were looking at nervous system abnormalities. We saw cardiovascular system abnormalities, and we are now looking at genitourinary. So many abnormalities can occur if the blood sugar level is high and there is hypoglycemia, especially during the time of organogenesis. Right, and babies can be either large for gestational age or small for gestational age. Now we talked about what is small for gestational age. Manelka, can you remind us? How do we identify babies with small for gestational age?
If baby is 2SD below the normal level.
Very good. And the reverse is large for gestational age will be what?
2SD is above the normal.
Very good, right? So if it has to be gestation specific, and if the birth weight is 2SD below the norm or minus 2SD, if the birth weight is below minus 2SD, that is small for gestational age. If the birth weight is above plus 2SD, that is considered large for gestational age. So both can occur in diabetes, right? So how can both occur? Large for gestational age, we will get to it in a minute. Small for gestational age can occur if there is vascular disease and there is poor perfusion of the placenta, right? So we saw this picture earlier also. So there is fetal growth restriction is seen in 20%, more than 2 times in a normal pregnancy. So that happens if there is advanced vascular disease in diabetes. Large for gestational age is seen in 15 to 45% of pregnancies where the mom is diabetic, right? So large for gestational age can mean it's above the plus 2SD or above the 90th centile, or in our Sri Lankan setting, more than 3.5 kilograms, because our babies are small as a whole, and our normal birth weight is actually small as a whole compared to Western babies. Okay. So what really happens when a mom has diabetes? What happens to the baby? So the mother's blood gives extra glucose to the baby, and the baby has to produce more insulin to handle the high amount of glucose that the baby is exposed to. And with the high amount of glucose, it is converted into insulin-like growth factor, and the baby becomes larger than normal, resulting in the large for gestational age baby. Right? So similarly, deposition of glycogen on the cardiac septum causes cardiac septal hypertrophy, right? Or it's called diabetic cardiomyopathy as well. So to get septal hypertrophy or diabetic cardiomyopathy, that is a consequence of too much of substrate. That is when the baby is exposed to large amounts of glucose that gets deposited either as glycogen or fat. So part of it can get deposited in the cardiac septa. So diabetic cardiomyopathy is not a sign to say that the mom has had diabetes during organogenesis. This can happen even with gestational diabetes, because this is associated with the amount of glucose that is crossing the placenta. Whereas the previous abnormalities that I showed you in the heart, in the nervous system, in the GIT, in the GUT, those happen when there is hypoglycemia during the period of organogenesis. Right? So this is hypertrophic cardiomyopathy. So let's look at a case history. 38-week, 3.5 kilogram baby born via elective section due to maternal diabetes was found to have a respiratory rate of 70 per minute with recessions and grunting soon after birth. 2 hours later, baby was found to have a respiratory rate of 100 per minute with more grunting. What are the possible underlying causes for this baby's condition? Kajini, what are the conditions? Do you know of any conditions that can occur that can cause respiratory problems in a baby of a diabetic mother? Can you think of anything?
Hypoglycemia, madam.
Okay, good. Anything else in relation to the respiratory system per se? What about this baby? Hypoglycemia can cause increased respiratory rate, but so much of respiratory distress purely due to hypoglycemia is less likely. Can you think of any disease affecting the respiratory system? Anyone else? Okay, so let's have a look. There are many causes for respiratory distress in a baby of a diabetic mother, right? IDM stands for infant of a diabetic mother. There can be transient tachypnea. So we will be having a lecture on respiratory distress, right? Sometime later, where we will go into pathophysiology. So transient tachypnea happens when the lung fluid, there is a delay in the absorption of lung fluid, right? So when there is diabetes, babies are delivered through elective section more than in a mother who doesn't have diabetes. So when a baby is delivered through elective section, there can be a delay in the absorption of the lung fluid because the baby has no idea that we are going to take the baby out. And because of this residual fluid, there is a period of tachypnea until the fluid gets absorbed, right? So that's called transient tachypnea. Respiratory distress syndrome is a usual disease that happens in preterm babies. But in babies, in mothers with diabetes, there is inactivation of surfactant. And therefore, a term baby even can get respiratory distress syndrome if born to a mother with diabetes. Then these babies have high amount of polycythemia, which can cause distress. Then they can have any other heart disease or the hypertrophic cardiomyopathy leading to cardiac failure. So these are the reasons why a baby can be having respiratory distress when they are born to a mother with diabetes, right? So this is the clinical context. When a baby gets respiratory distress and the mom there's a history of maternal diabetes, these are the things we should think about. So this is a chest X-ray. Can someone describe to me what you can see? Amandi?
Yes, madam.
Sorry? Amandi, I couldn't catch what you are saying. What can you see?
Madam, it's not, it's somewhat deviated from the midline. I mean, the way it is taken.
What can you see in the lung fields? Are they black? Are lung fields usually black?
They are not clear. Lung fields are not clear.
So they are like gray in color. This is called ground glass appearance, right? That means if you take a glass, smash it into little pieces and it becomes very unclear, like little sand bits everywhere. And if you look carefully, you may see air bronchogram, that is along the airways, you can see streak that is outlined in black. The reason is the alveoli have collapsed, so they look like little sand bits or ground dust. It's described as ground dust appearance. And so there you can't see air inside the alveoli. That is why the lung looks gray instead of black. And however, air is seen only inside the airways or the bronchial tree. That is why you say ground dust appearance with air bronchogram. So this is a typical X-ray of respiratory distress syndrome or surfactant deficiency. Okay, right. So what can you see here? Now this is a baby of a diabetic mother. This picture is from when the baby is inside the incubator. Nayanatara, what can you observe?
Large baby.
Can you observe anything in this baby that suggests by looking at the baby? Yes, very good. Large baby. What else? So it's a large for gestational age baby looks like. What about the face? Can you see face is very pink color? So baby looks polycythemic and the body looks yellow color, right? So the baby is jaundiced. So both these things are seen more commonly in babies of diabetic mothers, right? They have high levels of red cells causing polycythemia. And when these break down, they have a higher incidence of neonatal jaundice as well, right? So you can see large for gestational age, you can see neonatal jaundice, as well as you can see the rose or the red colored cheeks suggestive of a polycythemic baby. So polycythemia by definition, I'm sure you have done this for the BLS module, right? Is hematocrit more than 65% in neonates. We consider it polycythemia. And the pathophysiology is increased glycosylated hemoglobin can cause hypoxia as well as hyperglycemia. And the hypoxic element will increase the erythropoietin and thereby increase amount of red cells causing polycythemia, right? And we also saw that the baby was jaundiced. So the reasons why a baby of a diabetic mother is jaundiced, maybe that they had to be delivered preterm, maybe because of mom's complications. And if it's not, and if the diabetic is not controlled properly, I'm sure you heard the previous speakers say that prematurity is a complication. Then again, there's increased enterohepatic circulation, impaired conjugation of bilirubin, and in babies, there's decreased red cell lifespan, which gets worse with glycosylation. So because of all these reasons, jaundice is also commoner in babies of diabetic mothers. Then again, hypoglycemia is seen in 25 to 40%. So that's a large number of babies get hypoglycemic out of the babies born to diabetic mothers. And out of all the babies born to diabetic mothers, large for gestational age babies, as well as preterms, are at the highest risk. Now, can one of you tell me why babies of diabetic mothers get hypoglycemic? Osudi?
Madam, maybe because of the increased glucose level that is transmitted to the baby, insulin secretion in the fetus is high. And therefore, leading to hypoglycemia after delivery.
Why does the hypoglycemia come? Increased amount of glucose, increased insulin is correct. How does the hypoglycemia come? One more step is there. So once when the placenta is disconnected from the baby, that high glucose level stops, isn't it? But the baby's high insulin levels continue because of the beta cell hypertrophy. And for a little while, until the baby adapts to the new environment, the hyperinsulinemia will continue. So until the baby adapts, there will be a problem. So maternal hypoglycemia will cause fetal pancreatic beta cell hyperplasia, which in turn will cause high insulin secretion. And then at birth, what happens? The connection with the mom is no more once the baby is born, and the placenta is no longer in communication with the baby. So that causes an abrupt withdrawal of glucose at birth, right? And that is what actually causes the risk of hyperinsulinemic hypoglycemia. So the definition of hypoglycemia, it is taken as less than 2.6 millimole per liter or less than 45 milligram per deciliter. This is the World Health Organization definition, right? So let's see what happens to the blood sugar. So we know that glucose crosses the placenta and babies are used to whatever blood sugar level maintained in the mom. So in any baby, diabetes or not, when the placenta is disconnected and they are no longer in connection with the mom's glucose levels, there is going to be a drop of the blood sugar levels, right? So it takes a little while, takes 2-3 hours for the baby to adapt to this situation, right? So all babies have a sharp fall in the first 2 hours. We call this the nadir or the drop, right? And you can see the lowest level of blood sugar is seen around 2 hours of age. And then it slowly rises back to normal. So usually in about 3-4 hours, we would expect a baby without any other problem to adapt to the situation and normalize the blood sugars. So therefore, the important why I'm talking about this now is when we are screening for hypoglycemia, right? So in high risk babies, we screen for hypoglycemia because it has very adverse consequences. There is no point in screening soon after birth or within the first 2 hours. So we should give a little time for the baby to adapt to the postnatal environment. So therefore, when we screen the baby around 4 hours after birth before the second feed, right? So physiological adaptation in the neonate, some babies adapt slower than others. In healthy babies, they don't have a brain injury because the breast milk contains alternative fuels to glucose for the brain. Breast milk contains ketone bodies which can be used by the brain. And it also produces glucose via glycogenolysis and gluconeogenesis. There are other ways that the baby can produce glucose. So usually babies adapt to this by using alternate substrates as well as getting glucose via glycogenolysis and gluconeogenesis. Some babies do not mount this response. And some babies may not have alternative fuels. And in these situations, babies can have brain injury, right? So screening for hypoglycemia, we don't do it within the first 2 hours for the reason I mentioned, because everybody drops their blood sugar soon after birth and it takes them a little while to get it back, right? So because of that, we have to check the blood sugar before the second feed, that is around 4 hours of age. And to prevent hypoglycemia, we have to ensure that the babies are initiated breastfeeding within the first hour. Now, we have talked about this in the nutrition growth and development module as well, with regard to initiating the importance of initiating breastfeeding within the first hour. So another advantage of it, so we know this is needed for future establishment of breastfeeding. The success depends upon this initiation of breastfeeding in the first hour. Not only that, it also is important to establish normoglycemia in the baby, right? So checking should happen around 4 hours of age if there are indications to screen, which we will get to in a minute. And initiation of breastfeeding within the first hour will help to prevent hypoglycemia. So when we check for blood sugar, we should do pre-feed monitoring. The reason being, the blood sugar will be lowest before the next feed. The blood sugar will be highest after a feed. So there is no point checking the blood sugar soon after a feed because we want to know what's the lowest. And at the lowest time, if it is very low, we have to intervene. we have to also check for symptoms, right? We have to check whether the baby is having any other problems, is it symptomatic or asymptomatic hypoglycemia. And we may stop screening if consecutive levels are normal, right? So how do we diagnose a pathological condition? It is not only dependent on a glucose measurement, but also impaired metabolic adaptation. So we have to screen at-risk babies with blood sugar levels as well as clinical signs, right? So what are the clinical signs? The clinical signs are, the most common ones are reduced consciousness, changes in consciousness like lethargy, tremulousness, irritability, which are easily reversed by normalizing the glucose. The dangerous ones are coma and seizures, which can cause irreversible injury. And there can be variable signs like respiratory depression, cyanosis, hypotonia, inactivity, high-pitched cry, and all these other. Everything is very non-specific, right? You can have small things going wrong. So one of the first things you have to think is if a baby is not behaving like usual, whether the baby is hypoglycemic, and checking the blood sugar is very important. So when does the hypoglycemia cause brain injury? So low blood sugar, if there is no signs in the beginning, because the baby is able to use fat and glycogen, there's no brain damage. This is the period of biochemical hypoglycemia. Then you get the non-specific signs like lethargy and irritability. There's no brain damage yet, and that is the onset of impaired metabolic adaptation. Still, if there is no replacement of sugar, that can lead to severe clinical signs and fits, and which is due to failed metabolic adaptation. We may still escape damage if treated promptly. But we don't want to go to the clinical signs because that we may or may not be able to escape irreversible damage. So when there are clinical signs, we have to take it very seriously. So that brings us to the word operational threshold, right? So this is the level of blood sugar where we have to intervene. Okay. So this is higher than the concentration at which organ damage is known to occur, but lower than a treatment target. So the greatest risk of neuronal injury was seen in babies who got seizures and coma, and also who had a plasma glucose less than 1.1, that is less than 20 milligram per deciliter, where it was recurrent, or the hypoglycemia was persistent for 1 to 2 hours. So this is again MRI pictures where the hypoglycemia causes damage in the occipital lobes and it can cause irreversible injury, right? So treatment has to be guided by the presence of clinical signs as well as the level of blood sugars, because we want to avoid brain injury. So with regard to enteral feeds, right? Breast milk is better than formula because breast milk has high amount of ketone bodies which can be used as alternative fuel. Infant formula does not have this ability. So therefore, among enteral feeds or oral feeds, breast milk is preferred. So enteral feeds are used if the baby is asymptomatic with blood sugar levels between 1 and 2, and feed should be given at least 3 hours early. And formula milk will be considered only if there is no breast milk. That is, if the mom has died, or the mom herself is having some severe medical illness which contraindicates expressing breast milk. Intravenous therapy is indicated if the baby is having any sort of clinical sign or the baby is asymptomatic with blood sugars less than 20 milligram per deciliter. So in such situations, baby can be treated with a dextrose bolus followed by an infusion. Right? Bolus has always got to be followed by a dextrose infusion because otherwise there can be rebound hypoglycemia. And while we are doing this, so important things you need to make note is when do we need to start IV dextrose. So if the baby has any symptom at all, it's important to start. If the baby is, although the baby is asymptomatic, if the blood sugar levels are low, again, we need to start. Right, so severe persistent or recurrent, values of having this less than 20 milligram per deciliter, meaning we have to start. So this is basically, if you remember, in conjunction with the operational threshold, right? So this operational threshold as to when we have to start intravenous therapy, because intravenous therapy is more complicated. We have to prick the baby, put an infusion, and then although you use a bolus, you have to always follow it up with an infusion, because if you give a rapid rush of glucose, insulin also will go up. It remains high, and if you don't sort of supplement the baby with enough glucose, it drops down again and causes a rebound hypoglycemic effect. Right? So seizures of a diabetic mother can be due to. Okay, so let's see. Hansi Sammani. Can
Yes,
you
ma'am.
attempt this? Yeah. Hypoglycemia, do you think it's true or false, Hansi?
True, madam.
Hypocalcemia?
Not
It's okay.
sure.
You are not right. Yeah, this is your learning experience is this. You're not sure. What about the others? Do you have any idea about the other electrolytes? Okay. So let's see, right? So these babies born to diabetic mothers not only have issues with glucose levels, they can also have issues with hypocalcemia as well as hypomagnesemia, right? So they can have, if there are seizure occurs, there can be many reasons why a seizure occurs. It can be due to hypoglycemia, hypocalcemia, hypomagnesemia. So the first thing you have to do if a baby of a diabetic mother gets a seizure is what? Priyat? What is the first bedside investigation you need to do if you see a baby getting a seizure of a diabetic mother?
The serum electrolytes, madam.
But the serum electrolytes, the calling blood sugar, right? Serum electrolytes you have to send to the lab. It's going to take some time. So blood sugar levels you need to check. So seizures on day 1 is most likely due to hypoglycemia out of all these things. And again, the following metabolic problems are seen in babies of diabetic mothers, right? So these babies have several metabolic issues, which includes hypoglycemia, hypocalcemia, hypomagnesemia, as well as they can have issues with iron metabolism, right? So they don't have potassium issues, but they can have issues with calcium, glucose, as well as iron metabolism. Right. So advantages of breastfeeding the baby of a diabetic mother, right? Why is it important? It's important to breastfeed any baby, but a baby of a diabetic mother has some more advantages even than a baby whose mother is not having diabetes. These special advantages include that the risk of transmission of diabetes to the baby decreases by the mother feeding the baby breast milk. Also, mother's own glycemic control improves if she is breastfeeding the baby, and all the other advantages are there. The challenge is if the mother's diabetic control or the sugar control is not great, she may take longer to establish breastfeeding. So we need to understand this and be more patient and offer extra support to these mothers. Right, so I'm sure you remember the advantages of breastfeeding, that is species specific, it increases intelligence, immune benefits, lower allergy risk, less dental caries, less acute illness, then less non-communicable disease like less risk of heart disease, diabetes, obesity, all that, and maternal benefits. So in addition to all that, decreased risk of diabetes and better diabetic control for mom. So in summary, we talked about the complications faced by the infant of the diabetic, infant of the diabetic mother, as well as we talked a little bit about neonatal hypoglycemia and the preferred mode of feeding in these babies of diabetic mothers. Any questions?
Madam, why does it take time for the mother to establish breastfeeding if the glucose control is not good?
Because now in the initial bit of breastfeeding, it is under hormonal control, if you remember, right? Production is governed by what hormone? Remind me. Can you remember what hormone?
Prolactin.
Breastfeeding, yes.
Prolactin,
very good. Prolactin as well as oxytocin, right? Prolactin for the production of milk and oxytocin for the ejection of milk. So there are, hormones have effects on each other, just like, thyroid hormones have effects on the prolactin. Similarly, insulin also has effects on the prolactin. So with poor control, there can be the effects on the prolactin, which can sort of, take, if the prolactin levels are not optimal, the onset of, establishing breastfeeding can get delayed. then again, they tend to be obese sometimes. So there are other issues as well. So if they are obese and the breast size is very large, so again, obesity, the metabolic milieu of obesity also can delay breastfeeding. And in addition, there can be mechanical issues like if the breast is very large, it can be more difficult to establish breastfeeding. So, yes. So it is through the endocrinological things as well as, if they are obese as well, there can be structural issues as well, which makes it a little harder and which needs more support. You need to kind of, revise on what are the things that can affect the prolactin as well as oxytocin. Yeah, because it's in the hormonal milieu, there can be effects by other hormones. Yes, go ahead. Somebody else was asking something.
Madam, what is rebound hypoglycemia?
Rebound hypoglycemia means now we are trying to treat hypoglycemia that has occurred, right? So when we are trying to treat, okay, so we know that the amount of glucose is less, so we give a bolus of glucose. So bolus means you're rapidly giving a very large amount of glucose to the baby. So with that, how does the body respond? What will happen when we get a large amount of glucose to our body? What will happen with the body? What is the response?
Increase insulin, madam.
That's right. It will increase the insulin, right? And that will also increase maybe in proportion to the amount of glucose that is being given. And then suddenly it stops. Then we don't give anything at all. Now what happens? The amount of insulin is high, but there is no supply. And the blood sugar level drops rapidly. So that is why we say bolus has to be followed up by an infusion. So if the blood sugar level rapidly drops, we have iatrogenically caused another hypoglycemia. That is what is called the rebound hypoglycemia. Is that clear?
Yes, madam. Thank you.
Okay. Thank you for the questions. Any more questions? Anything that was not clear? So management of hypoglycemia in detail, it is given in the Newborn Guidelines 2020 as well. Right? You can access it from the Family Health Bureau website, volume 1. This was just the basics I touched on. So what you have to remember is like, when indications to give IV dextrose, then indications to, so the percentage of dextrose that is used in neonates is 10%, right? Please remember that, not 5%. And you can give only up to 12.5% through peripheral cannulas. If you try to give more, there can be issues. So you have to get central access. And babies who are screened for hypoglycemia, right? That includes low birth weight babies, preterm babies, babies of diabetic moms, all that. Any other questions? Okay, so if there are no other questions, I think I can end my session. Thank you. Thank you for listening.
Thank you, madam.